I focus on the molecular and cellular mechanisms and translational research in post-traumatic stress disorder. So I focus on the idea that PTSD is highly prevalent and very comorbid, one of the highest risks for suicide, substance abuse, and other disabilities. And yet we only have 2 FDA-approved drugs, SSRIs, that were approved over 20 years ago. Despite that, the genetics and neuroscience of PTSD suggest that there are many opportunities to take advantage of for the next generation of targeted treatments. And particularly, PTSD is the only psychiatric disorder that we know when it starts, by definition of the trauma. Therefore, the big idea is that in the same way today, if you have chest pain, you go to the emergency department, and with the right biomarkers, you can prevent the long-term sequelae of myocardial infarction. With PTSD, we can't do that. We can only do supportive treatment. Now we have predictive analytics leading to the ability to predict who's going to develop PTSD or not in the emergency department, and a new generation of drugs, one particular pathway I spoke about today, that we believe could be used for interfering with memory consolidation and blocking PTSD from developing in the first place. So we have both treatment and predictive biomarkers. One example is the amygdala. MRI signaling in the amygdala in the first weeks after trauma predicts highly who will develop PTSD at 6 months and 12 months later. Much more scalable, easy biomarkers include measures of the adrenaline response, for example, galvanic skin response, the sympathetic response. Even within an hour after the trauma, that can have a high level of predictability for PTSD symptoms and PTSD diagnosis at 6 months. Combining a combination of quantitative assessments, blood-based biomarkers, and physiological biomarkers like galvanic skin response can give us a prediction of about 85 to 90% of who will later develop PTSD early on after the trauma. So it turns out that memories aren't made immediately. Rather, memories go through a process of early molecular consolidation and then long-term structural consolidation. So if we could interfere with that trauma emotional memory consolidation in the first hours after the trauma or before the first night of sleep, we believe that in the same way that repairing cardiac function will prevent the long-term sequelae of myocardial infarction, preventing the over-memory consolidation of emotional memories after a trauma will prevent PTSD from developing. So industry collaborations can really build upon the current science, where there are a number of pipelines understanding molecular mechanisms of synaptic plasticity, memory consolidation, and prevention of PTSD. And those industry collaborators could be involved at different levels, from early stage development of lead compounds in medicinal chemistry, building on existing IP, to also in early phase 1 and phase 2B trials to show proof of concept in our emergency department networks. I think 5 years from now we could really be to the point where when people have severe psychological trauma, car crash, interpersonal assault, mass violence, there's specific protocols in emergency departments that can be followed within the first minutes to hours of coming into the ED with specific predictors of most people won't develop PTSD, they'll do their normal thing and will be okay. But some will develop PTSD. In that subset, we could identify, offer treatments to, probably a combination of biological and psychological treatments to prevent the long-term sequelae of PTSD in the emergency department or on the battlefield. It's a wonderful the World Medical Innovation Forum is a wonderful collaboration of industry, academia, and regulators to brainstorm together how do we improve health with the next generation treatments.